Okay. Hey, Dustin. Thanks for taking the time to sit with me and talk about medical abortion.
Yeah, pleasure.
So you gave a presentation on that today. Can you give a quick recap of the main things that you talked about?
Yeah, so medical abortion, the medical abortion pill, mifepristone, which is combined with another medication, misoprostol, was commercially available at the beginning of this year. So we now have about 11 months of its use in Canada. And so what we wanted to do was update the public and update providers today about where we're standing. So one thing we can say now is that most provinces have made a funding decision about mifepristone, and in those provinces that have, we do see that there is coverage. So most provinces now have some form of coverage, whether that's through the social assistance plan or if it's just if you have a health card that's there. In terms of other populations, we also found that if you are Indigenous and have non-insured health benefits or are covered under a refugee health plan like the Interim Federal Health, that the drug is now covered free of charge for you. The other thing that's we're noticing now is that we're actually seeing many physicians and nurse practitioners who are trained to provide it. So at the beginning of the year, people still hadn't signed up for the course, weren't ready, so women didn't have access to providers. Okay. We now know in Ontario alone, there are over 400 doctors who are trained to now perform medical abortion.
Okay, so it was covered in some places, but people weren't able to actually...
Correct. So one of the challenges for women is the drug may not be easily accessible because you don't have a prescriber, there isn't a pharmacist, or it's not covered. And so what we're seeing is rapid uptake. It makes me optimistic. You know, doctors want to fix this, they want to make the drug accessible, and they are taking the time to be trained, which is really good.
Okay. How would you say access is currently in Canada?
Yeah. So access is still a little bit spotty. It does depend on where you live and whether your provider has access to the drug or whether they feel comfortable prescribing it. Health Canada has recently relaxed restrictions on that as well, so anyone who's familiar with a medical abortion has done any number of training programs. The SOTC offers a very comprehensive one, but there are others, can now prescribe mifepristone. So physicians can prescribe it if they're asked by their patients, but some of them would like to do some legwork first to make sure that they're ready for it.
Okay. What are the advantages of mifepristone?
So the big advantages with medical abortion are that, one, there are more people prescribing it than there are surgical clinics. So particularly in smaller towns or places where there's a long wait list, it's easier to access abortion in a timely fashion. And one thing we know is that women like to access abortion options as fast as possible and not prolong their pregnancies once they've decided. The other thing is that it adds a different degree of privacy. So some women feel uncomfortable going to a hospital clinic where it's identified as being an abortion facility or a freestanding abortion clinic. Now they can go to their family doctor, they can go and see somebody else who will prescribe it, and basically no one from the outside knows if they're going for an ear infection or some other problem. And that also adds a level of normalcy to it. Abortion is a common experience for women. And so offering medical abortion recognizes that this is a common medical issue just like any other for which there is a safe and effective treatment.
Okay, so that does that have any impact on people who might have limitations to abortion because of cultural
Yeah, it's a good question.
issues?
So we know in certain religions that it's very important for women to have an abortion before a certain gestational age. So there are different cultural teachings around what we call ensoulment, the point at which a pregnancy becomes a potential child. So allowing women to access abortion earlier does help them. A lot of people also have their own general ethical idea about when a pregnancy is too far along for them to make this type of decision. So again, by allowing women to have abortion access, particularly before 8 weeks, where it's mostly placental tissue, it does help them to feel better about it.
Okay. And are there any drawbacks to this form of abortion versus going to a clinic?
One of the different disadvantages is that there's a lower rate of immediacy. A woman who goes to a surgical clinic usually will have an appointment that day, have the procedure, and then she can return back to life after the pregnancy. Medical abortion may require a few visits, so it may not happen right away. They're actually both very effective and very safe. So medical abortion isn't necessarily an alternative to surgical. They're really two equally appropriate options for a woman. Unfortunately, in some provinces and territories, the drug is still not covered, and so those women actually will pay less if they go to a facility for surgery than they would if they had to pay for the drug out of pocket, even though the health system would save money if they paid for the drug.
And is that, do you know which provinces and territories it's
Yeah.
not coming with?
So currently, we're still waiting for information from some of the maritime provinces. So we haven't heard from Newfoundland yet. We have not heard from New Brunswick yet, and we're still waiting to hear information from PEI, although that is increasing. We think that we're going to hear something soon. We know currently that if you live in Ontario, that you would have open access to the drug. We know that in Nova Scotia and Quebec, they plan to fund it, but the funding hasn't come through yet. So those women in those provinces would still potentially have to pay out of pocket. And then in BC, Saskatchewan, what we see is that if you have social assistance drug coverage, it's covered. But if you have your own employer's insurance, then you would have to get it covered through them.
Okay. And how's Canada doing on the world stage?
Yeah.
On this front, do you
Yeah,
think?
so Canada is slow to the start
Oh, yeah?
for mifepristone, actually. We're the 61st country worldwide to get the drug,
Oh.
despite being on the World Health Organization's list of essential drugs. And the first countries had mifepristone approved in 1988, so
Wow.
almost
And we just
30
had
years
it
ago.
last
Just this
year.
last year, yeah. But one thing that we've done in terms of taking a leadership position on it is that we've done a very good job of working with regulators to make sure that everyone agrees with what is the safe standard. We were able to turn around materials very rapidly. One thing that's great about Canada is that when we produce a guideline, it's published in both English and French. And in many countries where they're predominantly francophone, they don't have access to world-class guidelines. So we see the knowledge that we've gained in medical abortion as being useful in other countries. So I think that we should really be proud of the work we've been doing. I know Canadian women are getting a little impatient, but this is a medication that you hope you don't need to have, and that when you do need it, it's available to you. And I think we're almost there.
And to kind of switch from Canada to the international stage,
yeah.
how much of an impact do you think? Well,
Yeah.
this drug's been around for a while, right?
Yeah.
Is it prevalent in a lot of countries, or is it one of
Yeah.
the drugs that is very hard to access for
Yeah.
developing nations?
Yeah. Interestingly, in other countries, the drug is produced in an off-patent way. So in lower resource countries, they do have access to the drug that is less expensive, and that's common for many medications. China,
There are like generic
correct,
versions out there.
yes,
Okay.
yeah, and China, for instance, makes its own version of mifepristone. What we do know is that in countries where medical abortion is legalized or available, abortion rates don't actually go up. What we see is that the rate of medical goes up at the expense of surgery. So
Okay.
in countries where surgery is maybe not as safe as it is in Canada, it's actually really good to avoid surgery.
Yeah.
We also see in countries that have had mifepristone for a long time, France, for instance, 70% of abortions that take place are actually medical abortions. In 2012 in Canada, 4% were medical. And what we've actually seen already in Australia, which has had the drug since about 2012, already about 30% are medical now. So in 5 years, there's been a huge shift in the way that care is provided.
Okay. This might be a stupid question,
No
but you said that this doesn't happen right away, like a surgical.
Yeah.
So it takes a little time. Does that mean that if someone starts the process, can they
Change their mind.
back out of it and change
Yeah.
their mind, or does that cause
Yeah.
huge complications?
This
for
is
the
a
pregnancy?
this is a big area of controversy. So many medications that are used to end a pregnancy also have the risk of causing birth defects.
Okay.
And we strongly recommend as an organization, we strongly recommend as scientists that if a woman takes that first medication, that they continue on with the medical abortion. There is literature on the internet about what's called abortion reversal. It's really not based on good science. There are no big studies that show whether or not it will work. Mifepristone alone doesn't work particularly well as a medical abortion. It needs both drugs, but we would recommend that a woman only takes these medications if they're absolutely certain they don't want to be pregnant.
Yeah, because after the fact,
Yes,
there's certain defects that. Do
exactly.
we have a lot of evidence of what kind of defects
Yeah.
might?
So with mifepristone, there's only 2 case reports of the hundreds of thousands of doses. So it's actually not clear that it specifically is a teratogen, but we don't know. And we don't have long-term data on development, for instance. We do know that that second medication, misoprostol, does cause a series of birth defects in terms of skeletal development, so head shape and limbs. That can cause some issues. So we know that that is a potent teratogen. And although women have a very low chance of requiring surgery if the medical abortion doesn't go well, again, we have to remind women that there is a small chance, less than 5%, and that if they were to have an ongoing pregnancy, for instance, because the medications don't work, they would still need to have surgery.
Okay, but what typically happens if a woman does decide after, the first form of treatment that she
Yeah.
Decides she absolutely doesn't want
Yeah.
to go through with it or changes her mind, like what happens
Yeah,
then?
so the first thing she should do is contact the prescriber to get some advice on what to do. It's not clear right now whether taking progesterone type medications will reverse the effects. In fact, the way mifepristone works is it very quickly blocks all of those receptors, so probably adding the medication doesn't work.
Yeah.
I think that we would never, as physicians, force a woman to do something she doesn't want to do,
Yeah.
but we need to come back together and make a decision about what is the safest outcome for this potential pregnancy as well as for the woman. We do know that there is a chance that the pregnancy will fail anyways, and in which case the woman will have to reconcile that. We also recognize that some of these pregnancies would have resulted in miscarriage whether or not medication was used, and so we would work with the woman to help provide her with counseling and support to decide what the next best steps are.
Okay. But basically it should be treated as, if you make that decision, it should be treated like you're going in for a surgical abortion.
Yeah, so we would consider the moment you take that pill to be the point of no return, and that you would from that point on want to continue.
Okay, great. I think that's pretty much it for my questions. Is there anything else that you think should be mentioned to people on the topic?
I think it's really interesting to see this type of medication and to see the response from the public.
Mhm.
Most of the media coverage we see about medical abortion is very positive. This is a health equity and health access issue. And the fact that we're actually seeing pressure on provincial governments to ensure that it's funded, I see as a positive.
Mhm.
I think it's important that women have the option of using this, whether or not they'd ever use it in their lifetime. And in fact, this will result in savings to the system. I think it will result in better experiences for women. So I think this is a really interesting time in family planning and women's health right now in Canada, and it's good to see people getting passionate about it again.
Mhm.
For those who have political inclinations, for those people who just maybe don't see themselves as political, but recognize that everyone should have access to good health care. So it's nice to see people engaging and taking interest in their own health.
Awesome.
Yeah, it's great.
Okay, great. Well, thank you so
Great.
much. Appreciate it.
Thank you.